It gives me great pleasure today to introduce somebody who I have got to know virtually over the last 18 months and who it has been an absolute pleasure to work with. And that is Professor Cheryl Cohen, who heads the Center for Respiratory Diseases and Meningitis at NICD, and who's also a professor of epidemiology at the University of the Witwatersrand. And she's going to be sharing with us results of what is called the PHIRST-C Cohort Study, which is really a masterclass in how to conduct a study to understand the epidemiology and the clinical epidemiology and transmission of a new pathogen, or really of any pathogen, and answers a huge number of questions in terms of what we need to know about SARS-CoV-2 in our setting. So thanks very much, Cheryl, for agreeing to present. We're really looking forward to the talk. Cheryl, we are recording, and I just want to check with you if that's okay, or if you prefer us not to record.
That's fine.
Okay, fantastic. Thank you very much. I'm hoping that I can make this available to my students in infectious disease epidemiology so they can learn how to do these kind of studies. So thanks very much, and over to you.
Thanks, Marianne. I'm going to try to put it in. Can you see my screen?
We can. That's perfect.
Yeah.
We can see it, and we can hear you.
So thanks very much for the opportunity. I know I've presented these data on some forums, so I hope it's not all repetition. And this slide deck, Marianne said I've got a bit more time, and so it's a bit more of a comprehensive slide deck. And so for those of you who've seen the talk before, what I've added in is a bit more on the methods. And then at the end, I've got some, and most of my talk is, in fact, is available in a preprint on medX-RIV, but I've got at the end some modeling work, which is new and it's not sort of being presented anyway. But yeah, so thank you very much. As Marianne indicated, PHIRST-C is really a very intensive study. I mean, certainly my colleague Stefano Tempio, who's worked with me on all the PHIRST studies we were just discussing yesterday, it is really an infectious diseases epidemiologist's dream study, though, because as you'll see, really it's the kind of study, if you're into this sort of thing, it's a real privilege to have been involved in. But really it was a lot of work, and I just wanted to start by acknowledging the main partners for the study, which is the Perinatal HIV Research Unit and the MRC Wits Agincourt Unit, who implemented the field aspects of the study at the urban and rural site. And you will see that that was really a very intensive component, as well as the US Centers for Disease Control and Prevention that funded the study, and also were technical partners in the study. So just as background, we're all very familiar with this curve, and I haven't fully updated it. But we all know South Africa's now had 3 SARS-CoV-2 waves. The first was so-called wild-type virus, and then the second was dominated by the introduction of the beta variant, and we're now in the wave, or sort of peaking or passing through the Delta variant wave. But just to mention, our study goes up to about the end of March. So the data I'll be showing you now really covers those first 2 waves up until the 31st of March 2021. So the data are censored until that point. And also to mention, the PHIRST-C study builds on a previous study we did, which was called the FIRST study. And the FIRST study was a study we did from 2016 to 2018, really aiming to understand the burden and transmission of influenza, respiratory syncytial virus, pneumococcus, and pertussis. And for these pathogens, as in the first study, we were really thinking that actually there's very little known about asymptomatic infections and the role of asymptomatic infections in driving transmission. But if we want to start thinking about control strategies that use vaccination or other interventions to target the transmitters rather than perhaps targeting risk groups as we do for influenza traditionally, then we really need to have study designs that can capture asymptomatic infections and allow us to understand them. And so the results of the flu study were published just recently in the Lancet Global Health, and you can see really from the headline findings that it was focusing on asymptomatic infections. We found that about half of flu infections were symptomatic, and also for flu, that asymptomatically infected people could transmit flu, and this was not really known for flu, and a lot of those messages were around vaccination of children and other techniques. And what happened was, so it was a very big study. We all heaved a sigh of relief when we finished in 2018. But then beginning of last year, when COVID emerged, I think it very rapidly became apparent that these questions around the burden of asymptomatic infections, the role of asymptomatic individuals in transmission, the role of children in transmission were very important. And so essentially, those of us who'd done the original FIRST study decided that we would try and get funding and restart the study with, as you'll see, it's quite a unique study designed to try and address these questions for COVID. And the FIRST study really addresses questions in two broad pillars. The first pillar of questions is around burden of disease. So really trying to estimate the burden of infection and illness, in this case, in relation to SARS-CoV-2, and that burden measured both through PCR confirmed infections as well as through antibody or immunologic responses ascertained on serology, and also to understand the relationship between these two ways of measuring infection burden. And we also wanted to look at other things like incubation period, importantly, the percent of cases that have symptoms or asymptomatic. And we weren't sure if we'd be powered, but because it is a community study, but we hope to be able to look at severity as well. And then the second big pillar is really understanding the transmission dynamics within the community. And this is really, so who introduces the disease into the household, and who are the individuals who are driving, and what are the factors that are driving transmission, particularly within households. And then we had a specific focus really on age groups, so the role of children, as well as HIV infection. The study is a prospective household level community cohort study. It was conducted in two sites. You can see in the green, the rural site in Mpumalanga, and in purple, the urban site in Klerksdorp. At each site, at the sort of last year, we randomly selected 100 households, a little over 100 households, to participate in the study. And these individuals, these households were selected from households who participated in the initial FIRST study, and those households were essentially a random selection of households from the community. So the idea was to be as representative as possible of the community from which the households were drawn. And in the end, we aimed to have over 1,000 individuals in the cohort. And then on enrollment, we really verified eligibility, which included things like we needed more than 2 people in the household, etc. And then we also got their baseline data, age, sex, occupation. We took blood from everyone to verify HIV status, and we got viral load and CD4 count on the HIV infected individuals. We got information on underlying conditions and a bit about the house as well, how people lived and crowding, and some economic indicators. And then essentially, once these households were enrolled, we followed them up very intensively for what will be now 14 months. So because of the third wave, we extended our follow-up, and we are ending at the end of August, and this will be the actual end. We have had some extensions, but this is the final extension. So we have followed people up from July of last year until August. And what we do with all the participants, we visit the household twice a week. The first visit must be Monday to Wednesday, second Thursday to Saturday, and we take a mid-terminated nasal swab from every household member twice a week, and we test that for the presence of SARS-CoV-2 on PCR. And then we ask people at the same time, do they have any symptoms, and have they had any healthcare contact? And we also take blood every 2 months, which we test for the presence of SARS-CoV-2 antibodies. After the end of August, we will do some serologic follow-up until the end of the year. All the data is captured on REDCap in real time, and we do checks in real time. We report all the SARS-CoV-2 positives, and we notify them. And then, then we have a safety committee as well that has helped us. In the beginning, it was quite difficult. We had to organize PPE and consider a number of safety issues for conducting the study in the field. And we also have a scientific advisory board that has helped us with a number of aspects. This is just some photos of the sites. On the left, you see the rural site. You can see quite a big house. A lot of procedures are conducted outdoors, and people spend a lot more time outdoors, and then the urban site on the right, much more typical of many South African urban townships. A big house in the middle, some metal structures in the yard, not a lot of outside space. A lot happens indoors. And I think, these sites are fairly typical of other similar communities in South Africa. In terms of lab methods, for our serology, we used the Roche anti-SARS-CoV-2 nuclear capsid assay. We chose this assay because of all the assays, it's been shown to be highly sensitive and specific and particularly durable in terms of long-term antibody responses. So compared to other assays, it doesn't wane so much. We also have done an in-house spike ELISA, and we are planning neutralizing antibodies on the participants, but I'm only going to show you the Roche results. And then for PCR, we use the C-gene commercial assay. It looks for three targets, and if it's positive for any one, according to the manufacturer, that is a positive. However, because we were doing so many tens of thousands of PCRs, we wanted to increase the specificity of our PCR positive diagnosis. So in order to do this, any positive we had on the initial PCR, we reconfirmed it through taking a second aliquot of the same sample, re-extracting it, and running 2 more PCRs on it. And we only called a positive if it was confirmed on a second positive PCR. And then for lineage or variant determination, we used the C-gene variant PCR-based assay. We have done sequencing as well on a number of samples, but I won't show those data. So there are a number of challenges in a study like this in terms of definitions. And the first one is really, how do you define an episode of infection? We know people can test positive and then test negative and then test positive again. And so for us, what we really decided to do was define an episode as if a person is positive at least once, that is an infection episode. And the duration was the first to the last positive swab. But if a person tests positive and then negative again, any repeat positive within 28 days of that first positive is considered to be part of the same episode. If a person is positive and negative for 28 days and then they become positive at any time thereafter, that would be called a repeat episode. And then to define a serologically confirmed episode, it was any instance of antibody positivity. Then related to that flow, then our definitions of reinfections, right? And we try to grade our reinfections as has been done in the literature by other people, because obviously you can't be sure. If I'm positive today and negative 28 days and I come positive on the 29th day, you can't be certain it's a reinfection, or it could just be long shedding. And so we called a possible reinfection somebody who's a positive more than 28 days after another episode, but less than 90 days. The probable reinfection was if there's more than 90 days between the two. I mean, it's highly likely that that second episode is a true reinfection. And then it was confirmed if we had evidence that it was actually a different virus causing the first episode and the second. And this could be through PCR or through sequencing information. And then we worked out the proportion reinfected simply by dividing the number of people who had at least one infection, by the number of people who had a second infection over the total who'd had at least one infection. And in addition, we did an analysis, which I'll show you a bit later, to try and work out how much protection is conferred against reinfection by previous infection. And in fact, I'll show you, I've got it written here, but I'll show you, it's easier to show you in the figure a little bit later. And then we similarly had to make definitions about clusters. For household clusters, we called any episodes in a house that occurred within 2 weeks of one another were called the same cluster. But if a household had no infections for 2 weeks and then a new infection, it was considered to be a new introduction in the household. We took the duration of a cluster from the first positive in the household to the last positive in the household. And then you'll see for the transmission, we used what we call the HCIR, or the household cumulative infection risk. This is really given a single infection in the household, what % of other susceptible household members acquire the infection. And for this calculation, we only included houses that had a single positive primary case. So where we could say this is the first person who introduced it. If 2 people tested positive on the same day in the household, we didn't include them in this sort of simplistic deterministic analysis. So that's a little bit on methods. I went a bit fast in the discussion. We can, I can take questions if there are questions about the analysis. But moving on to the results. So for this study, we approached 537 people or households. And then in the end, we ended up including in our study 222 of those approached households. The main reasons for exclusion would be that the households had two or less individuals in them, and we wanted to have at least 3 people, because to look at transmission you need a few household members. Or our second criteria was that at least 75% of people had to agree to participate, because again, to study transmission, we wanted the majority of household members to be in our study. And in those 222 households, there were 1,249 people residing, of whom 1,189, so 95% of all the people actually living in those houses did agree to participate in the study. So we got almost, the vast majority of household members in the houses included were participants. And just a little bit in terms of the characteristics of the cohort. You can see the age distribution really reflects the age distribution in those 2 communities. Not very many elderly, 10% or less elderly, more children in the rural site, and a predominance of women, which reflects the demographics in those sites, particularly the rural sites. A lot of men are migrant laborers. But it also does reflect some bias in our enrollment, in that often in the household, if one person didn't participate, it was often the adult male household member. So there is some underrepresentation of adult males compared to the community from which these cases came. You can see vast majority were unemployed, and quite a big difference with alcohol and smoking between the 2 sites. And just to say, the median number of people in the household was 5, which was the same at both the sites, and it was the same as the communities from which these people were drawn. Okay, so this figure, it's quite a complex figure, but it has a lot of useful information in it from the study. So I'm going to spend a little bit of time to take you through it. On the left, you see the rural site, and on the right, you see the urban site. And we can just start here in this top box, which really shows the results of serology and PCR. So this x-axis is time. These are the visit numbers, and then here you can see the date, starting in July of 2020 and going up to end of March of 2021. And this axis shows the percent PCR positive for each test that we do, and you can see here really it runs at about 2 or 3% in the rural site, until we get this very big second wave in the rural site, and going up to almost 10% positivity and then coming down again. So in the rural site, really they had a very small first wave, and at the start of the study, not a lot of people had been infected. And then on this figure, you can also see there's these lines here, which are really the cumulative percent of people at the site who test positive, in the purple on serology or PCR, and in the blue on serology only. So you can see at the start of the study in the rural site, very few, like 1% of people had evidence of previous infection, and it slowly increased until the second wave. And then you can see after the second wave that the dashed blue line and the purple line really bump up quite a bit, up to sort of about 25%. And that really shows after the second wave, a high percent of people had been previously infected. And if you look on the right at the same figure for the urban site, you can see quite different in the urban site. In the urban site, we started follow-up just after the peak of the first wave, in fact. So you can see there in the red that the proportion testing positive was probably a little bit higher, and then we really started sampling people on the down side of the second wave. That second wave also was a bit stretched out in the urban site, and the first wave was a bit stretched out, then it went down, and then you can see the second wave in the urban site, and then even some ongoing positivity after that. And you can also see in the urban site that the seroprevalence was quite a bit higher, starting around 10% at the beginning of the study, and by the end of the study, after the second wave, up to about over 40% of people had evidence of previous infection. So that just tracks the overall epidemic trajectory. Now, if you look at the middle figure, these middle figures here, these are what we call mosaics, and it's an array really of displaying, quite a lot of information about the laboratory test that we did. So in this figure, each row is an individual, and the different people in the same household are all stacked underneath one another. And then each column is a visit, and we color the block a different color depending on the results of the PCR. So if it's gray, it means we didn't take a swab. If it's the light pink color, it means we took a swab, but it was negative for SARS-CoV-2. And if it's the dark red color, you can see that means the person was positive for SARS-CoV-2. So you can see certainly in the first part in the rural side, most people are negative, most swabs are negative, but you do see these infections here. People, wherever it's red, somebody's positive, and then if it's a long line, it means they shared for quite long. And you can see also where there are like lots of red underneath one another, those are little household clusters of infection. So the first one would be the person who introduces it, and then other people in the household gradually come positive, and then the infection dies out. These white bars are just, this is Christmas time where we only did 1 visit a week instead of our normal 2 visits because of the holidays. And so really the urban site, very few infections around the first wave, sorry, the rural site, very few infections in the first wave, and then this very big second wave, lots of infections, and you can see lots of household clusters. In addition, in this figure, we've also included results of the serologic analysis. So that's in blue, these 2 monthly blood draws. And if it's light blue, it means the person is seronegative. And if it's dark blue, they are seropositive. And you can see in the rural site, initially, most people are negative. And then after the second wave, you see more and more dark blue coming up. And those are the people that have now seroconverted and become seropositive in our study. And then again, there's a similar figure on the right-hand side. For the urban site, many more infections in the first wave, so there's a bit more red there. Also more seropositive at the beginning, a slightly smaller second wave in the urban site, but still quite a lot of infections and clusters, and then even more seropositive later on. And you can see in both waves, really, there were ongoing infections when we censored the database for this analysis. And then at the bottom, this is really just showing you the different variants that are included in our analysis. Essentially, so this is, again, the same x-axis, the proportion due to 2 variants. WT is wild type, so the original SARS-CoV-2, and then the red is variant of concern. And for this analysis, essentially, it's all beta variant. And you can see, really, the replacement was quite quick. So for some of the analyses, you'll see we defined the first and second wave, and we took that really a line through this white visit. And you essentially, anything that's in the second wave, 95% of infections in the second wave were beta, and anything in the first wave, 95 were wild type virus. So there was really quite good discrimination simply by taking that time point in between the variants in the first and the second wave. And that was consistent for both the sites. So very rapid replacement by beta in both sites for the second wave. In terms of follow-up, there were 76,940 potential follow-up visits, and of those, we managed to get a swab and test it for 93% of included people, and of those swabs, 1% of them tested positive. But remember, these are just positive swabs. It doesn't tell us really about episodes of infection, which is what we're interested in. So if we translate those into episodes of infection, we see that by the end of March, 73% of households had at least 1 episode of infection. 3/4 of all households by the end of March had at least 1 person in the house that had SARS-CoV-2. And then on an individual level, it was about 34%. So just over 1/3 of people had evidence of a previous SARS-CoV-2 infection. And this is the same data just displayed now by age. So the bar graph on the left for the rural site, on the right for the urban site, showing the percentage of people with evidence of infection either on PCR or serology or both. And you can see in terms of age distribution, it's fairly consistent. In both sites, people between 13 and 59 years of age have a higher prevalence of infection, but the rates in kids are not low, around 20% or more. Yeah, and the picture is quite similar for the sites, but obviously more infections in the urban site compared to the rural site. And this is probably connectedness. Our rural site really is quite, it is a very rural site, and so it seems the virus takes a bit longer to get there. In terms of correlation between serology and PCR, we saw very good correlation. So of the people with a positive PCR in our study, 90% of them also had evidence of seroconversion. So we know a small number of people don't ever develop antibodies to SARS-CoV-2, so this does reflect them. And there were no significant predictors of seroconversion, but the numbers were small in that analysis. If we look at the converse, at all the people who were seronegative at baseline and then became seropositive, similarly, 87% of those, we were able to get evidence of a PCR-confirmed infection. So essentially, in the seroconverters, when we swab twice a week, we get the vast majority of infections also on a PCR, but we do miss some, and those can be because maybe it was very short shedding, maybe there was a problem with specimen quality, maybe the person traveled during the episode, or there was an issue with the PCR. So a small percent we missed, but in essence, a very, very good correlation. In terms of factors associated with acquisition, so what are the risk factors for having caught COVID or having at least one episode of COVID in our study? Age was most important, and the only other factors was site. So we said the urban site, and then obesity was also associated with an increased risk of acquisition. And this is being described. It's probably to do with ACE receptors, that obese people have more ACE receptors present, but no association with HIV. In terms of symptomatic friction, and this is one of the most striking results of our study, only 17% of all the PCR confirmed infection, and remembering most of these were also confirmed on serology, reported any symptom. And this is despite the fact we were visiting them twice a week and asking them if they had symptoms. So, and just to say, this is a very low symptomatic fraction compared to the global literature. Most studies would say around 50% maybe would be asymptomatic, or even less. So this really is a very low asymptomatic fraction, and I think it's not clear how much of that is perhaps a specific epidemiology that we see in these rural and urban communities in Africa, or how much is about our very intensive study design. And if we did this type of study in Europe or North America, perhaps we would see such a high symptomatic fraction. And you just to see the symptoms, I mean, really fever and cough, very uncommon symptom, but cough is among the commonest. Just to say, this doesn't mean the infection was necessarily mild. So although we only had few symptomatic individuals, there was quite a high burden of severe disease in those symptomatic people. So 6 were hospitalized of 43 with symptoms, and 1 person died, which is much more than we saw, for example, in our influenza study, where we had no deaths and very few hospitalizations, if any. In terms of the factors, and there is someone with background noise. I don't know if you can mute them, maybe, Marianne. Factors associated with symptoms, very interestingly, the only factor associated with symptoms was age. So being over 40, you had a higher chance of symptoms, but even in that age group, only about 30% had symptoms, and really nothing else statistically significantly associated with presence of symptoms. Another thing we looked at was duration of shedding, and in this analysis, the mean duration of shedding was 12.5 days, with a median of 11. And in terms of who shed for longer, this is a hazard ratio, so the lower the number, the longer the shedding. It was elderly people who shed for longer, and then perhaps, as you would expect, people with a high viral load, as using a proxy of a low CT value. And if you had more PCR targets positive on the assay, those were the people who shed for longer. And then also importantly, the beta variant. So people infected with the beta variant also had longer shedding compared to with the wild type variant. And we'll talk about transmission a little later, but this informs the transmission analysis. If we look at clusters within households now, so moving on to transmission, you can see that many households had clusters, but actually, sorry, I seem to have missed out reinfections. I'll go back to reinfections. I don't know how that missed in my slide deck. I'll go back to in a minute. So many households had more than one cluster. So in fact, 21% of households with at least one infection had 2 clustered, and 1 even had 3 clusters. And the household cumulative infection risk was 16%, which this is very similar to what we would normally understand as the secondary attack rate. So what percent of people get infected if you have one infectious case in the household? If we look at the factors associated with the household cumulative infection risk, so what is associated with transmission, we can see that the viral load was important, a low CT value, high viral load, and then the beta variant, very strongly 4 times increased risk of transmission, and then also the urban site. But importantly, age had no association with transmission, and neither did symptoms. And then just one other result on this is that the children also were less likely than adults to introduce SARS-CoV-2 into the household. So even though children were not less likely to transmit, they were significantly less likely to be the index case. So mostly kids are getting infected by adults or older people introducing infection into the household. I'm sorry, I'm just going to go out. I didn't talk about reinfections, did I, Mary Ann? Did I go through the slide? Yeah, I don't know why the slide skipped. I'm just going to go back and then I'll move on to the modeling results. So I don't know why it didn't show in the deck, but just to mention the reinfections. So very interestingly, in the study design, we're really able to, it's one of the best study designs to really quantify, what proportion of people actually do have a reinfection. And until the end of March, we found that 3% of people had a reinfection. And when we classified those reinfections, 1 was confirmed, 5 were probable, and 6 were possible reinfections. Now, using that information, we could really do an analysis, and I'll show you later the modeling analysis, but this is just a more deterministic analysis to look at how much protection is conferred by previous infection against reinfection. So what we did for this is we censored everyone at the end of the first wave. And at the end of the first wave, we classified them as either having had a previous infection if they had evidence on PCR or serology, or never having had a previous infection. And then we followed those 2 cohorts up through the second wave to look at the attack rate in those with evidence of previous infection and those without evidence of previous infection. And what we found is that it was a much lower attack rate, 3% in those with previous infection compared to 18% in those without. And when you put that in a sort of a vaccine effectiveness equation, you get an estimate of about 84% protection conferred by previous infection. So this is, in the first wave, infection with the wild type virus confers 84% protection against infection in the second wave, which was overwhelmingly with the beta variant. And this is important because the immunogenicity data suggests, in fact, a lot of fallout of neutralizing antibodies from wild type to variant. But in fact, our study suggests that even though you may not have so many antibodies, there is protection. And in fact, this 84% is very similar to what was found in the Siren study and other studies in the UK mostly, which try to look at this aspect of protections. And those studies didn't have the variant. So it's not that different from what you would see wild type infection. So let me just go down. So now I'm just going to shift, because I had a bit more time, I've just added in a few slides. I haven't shown that much. So this is just on generation interval. Generation interval is really the interval between the onset of PCR positivity, in this case, in the index case, to the onset in the secondary case. And we found a mean generation interval of 7 days. So 7 days from the first case to the second case, with a range of 2 to 16 days. And the factors associated with this, again, it's very similar. It's these biological factors, the low, the many PCR targets, which again is a proxy, I think, of viral load. And then potentially the second wave, it was slightly longer. And then the longer you shed, the longer the generation interval, which also makes sense, right? Because you can infect people later on. But again, age and HIV, those things not really coming out in the model. So I just want to use a little bit of time, maybe 10 minutes, to take you through a different analysis of the same data. So this analysis was done by Kai-Yuan Sun at the Fogarty Institute with Cecile Verbeau, his supervisor. And essentially, he took the data from our first study and he put it into a different analytic framework. He developed a sort of a model to try and look at some of these questions, particularly around reinfection, and see if he could get a more robust quantification of the protection conferred by previous infection, and also whether he could look at wild type versus wild type variant or protection, different combinations. So the first thing he did is he tried to, using a more modeling analytic framework, look at the viral shedding dynamics. And here you can see what he did. He graphed every little red dot is an actual CT value from an individual, and then he sort of plotted these all with the gray line sort of to join them up and really try and estimate the trajectory of viral shedding. And he used an analytic framework that was developed with a basketball. There was a study where they had a whole lot of people, basketball players, where they swabbed them very regularly, similar to PHIRST, and they developed this analytic approach. And he really showed this very rapid upswing in the viral load, and then a sort of longer downswing. And he actually quantified the different stages. So he found that his estimate was 11 days was the mean shedding duration, and he broke that into the so-called proliferation stage, the ascending phase to peak viral load, which was about 3 days, and then the descending phase, which was about 8 days. And he got an average peak viral load of 23. And then what he went on to do is he looked at 2 different analyses you can see at the right. Firstly, what are the factors associated with peak viral load? And what he showed was essentially the main thing is that if you've had a previous infection, so if you're a reinfection, your viral load is much lower. And similarly, in terms of duration of shedding, if you're a reinfection, you also shed for shorter. So he showed that really reinfections have a lower viral load and they shed for shorter. And this is important because it may be potentially associated with decreased onward transmission. So even though you have a breakthrough infection, you're less infectious than if you were a primary case. And there is similar data for vaccine breakthrough infections. He then did this model where he really tried to look at what are the factors associated with infection acquisition. So this is really infection acquisition, and he restricted this analysis to the second wave, because that was the wave where we had the full upswing and the downwing swing, and he was worried about bias and confounding in that first wave, which was cut off. So just in the second wave where we had the full wave, he looked at the factors associated with viral transmission, and you can see very interestingly, he found, okay, so a household size was important, a bigger household size, and then very importantly here, you see the protection conferred by a previous infection, and you can see very nicely here, he showed that if you had a previous wild type infection, it was 79% protective against infection with beta. If you had a previous beta infection, it was 89% protective against infection with beta. So there seems to, but it wasn't statistically different. So there may be a suggestion that the homotypic protection against the same variant is slightly higher than heterotypic protection, but not statistically significant. And then he also showed very beautifully that in the proliferation phase, you're actually more infectious. So the CT value, association of CT value with transmission is higher in the proliferation phase compared to the clearance phase. So suggesting that if you're more infectious on the up wave, and on the down wave you're less infectious for a given CT value, and that's probably because already you've got antibodies that are neutralizing that virus. And then he also showed that the community force of infection is also important. So the more virus there is in the general community, the more likely you are to acquire infection. And this analysis is much more robust than the sort of simplistic one I showed before, because here you can see he's really accounting for things like, is there an infectious case in the household? What is the force of infection from outside the community? So it's a much more detailed analysis that he can do in this modeling framework, and probably a more precise and valid estimate of the protection. And then just to say, he did a sensitivity analysis where instead of just restricting to the beta variant, he included all the cases that we had just to get a little bit more statistical power. And interestingly, he did get a suggestion. Oh, sorry, and I see I've cut off the legend here, but he got the suggestion, in fact, in terms of risk of acquisition of infection, that in fact HIV positive immunosuppressed individuals, so he stratified the HIV into not immunosuppressed or immunosuppressed, do seem that they may actually have a higher risk of infection acquisition. There was a signal there on the beta analysis, but it wasn't statistically significant. So I think this is sort of hypothesis generating and needs to be explored a bit more. And then this is the last sort of slide in terms of results. So then what he did is he sort of tried to synthesize all of that to answer the question we are all interested in, right? Have we seen sufficient infections to be able to interrupt transmission? And if we haven't yet seen sufficient infections to interrupt transmission, which is really around herd immunity and herd immunity effects, how many infections would we need to see before we can interrupt transmission? And so in order to do this, essentially what he did is he parameterized his model from the data in PHIRST. So he assumed imperfect immunity. He assumed that previous infection confers 80% protection against reinfection. And he also assumed that if you are a breakthrough case, you are 50% less likely to onward transmit the virus. And he based this on the fact that the reinfections have a lower viral load and a lower duration of shedding. And then he took 3 scenarios for which there were available published estimates of the basic reproductive number. So that's this axis. The wild type, where the basic reproductive number estimate is 2.5. The alpha variant, where the basic reproductive estimate is about 3.75, and then delta, where the estimate is about 5.6. And so he took those two, and then he overlaid on it these assumptions and the observed prevalence that we saw after the second wave in the rural site, which is around 25%, and in the urban site, which is around 50%. And he looked at, how far are we from the herd immunity threshold? Now, the herd immunity threshold is this dotted line. And this is the infection attack rate is really the percent of people in the community that have already had infection. And so what he shows is that essentially we're very far from the herd immunity threshold, even if the virus around was still wild type, and maybe we have reached it now after the third wave and we get to 65%. Certainly here, or after the second wave, we were far from the herd immunity threshold. If we got to 65%, we may have interrupted transmission. But of course, now with the Delta, you know, this really projects is that you'd need to get sort of 90% of people infected to have any hope of interrupting transmission. And this model doesn't account for waning immunity or other factors. So essentially, what it's saying is that with these highly infectious variants like Delta, herd immunity, as we classically understand it in terms of the interruption of transmission, in other words, dropping the effective reproductive number below 1 through increasing immunity in the population, is essentially not achievable under the parameterization from our model in terms of protection conferred by previous infection, which is a sobering consideration. So just I mean, some concluding summary really, high attack rate after the third wave, about a third of people infected. I'm sure after this last wave it's more. Age is important in terms of that attack rate. Serology and PCR really correlate well. I think it really validates the information we get from our sero surveys. Very low symptomatic friction, which essentially implies that in South Africa anyway, the vast majority of this COVID pandemic is happening under the surface. But those asymptomatic people, they can transmit, and much of the transmission is happening below the surface. But the bit that projects above, the symptomatic disease, is severe and does cause substantial morbidity and mortality, as we all know. And this is different from what is seen in the literature. Just for contrast, in our flu study, 56% of people were symptomatic. So COVID is much more asymptomatic than flu, it appears. The transmission, very similar. Interestingly, although almost all of our index cases were asymptomatic, our transmission was absolutely point on with the point estimate from other studies of 16%. And then we found viral load to be important. And then, as I mentioned, I think synthesized our information on the beta variant. There was always a question, this big second wave we had from beta, how much was escape from immunity from previous infection? How much was increased transmissibility? Our data suggests the main reason for the big second wave we saw was increased transmissibility. The immune escape was not really the major factor, although there is a suggestion there may have been some. And that the beta had a longer shedding duration and more infectiousness. Now, obviously, beta is now old news, and Delta is the big question. And for that reason, in fact, we've extended our follow-up until end of August. So we should have captured the full Delta wave in both of our sites. We hope to have some analysis of those data in the next month or two to hopefully be able to look at some of these questions. The other big analysis that we're trying to do is we're doing neutralizing antibodies on everybody, and we hope to be able to look in more depth at correlates of protection. So in a similar analysis framework to what we did for the modeling, really to be able to account for different factors like force of infection in the house and the community, and then relate the level of neutralizing antibodies to protection against reinfection. So really, just to conclude, a very, very intensive study, huge amount of work from the lab and the field teams, and really to acknowledge, the many, many people and the funders that made the study possible. Thank you.
Thanks, Cheryl. That was absolutely amazing. I have heard parts of this talk before, but I am again blown away by just the depth of knowledge, the detail, the care, and how many insights we have gained from this study. There are a couple of comments in the chat already and questions, so perhaps I will read all of those out, and then you can take all of those together. I'm not sure because you may not have access to the chat.
I can't see. Yeah, okay, I can't see. Sorry. I'll make notes. It's fine.
Okay. So there's a question around the small proportion of asymptomatics from Virginia Zweigenthal. And the question is, do you think people minimize their symptoms and say it's just a snotty nose, it's just my allergies, etc., and therefore don't report them and think of that as just their usual state? And I guess I would add to that although they did get their results reported to them, obviously people reporting symptoms can't go to work. So was there any incentive to not report symptoms because then you would need to isolate immediately? There's a question around children under 5. This is from Jem Patton, who were as likely to transmit, but less likely to be the index case. And do you have an explanation for that? And then from Carl Morrow says, this is fascinating work, really getting to the root of the biology and ecology of the disease. And have you gathered social interaction data like close and casual contacts by age? And Carl is particularly interested in ventilation. So have you looked at building design, ventilation, CO2 concentration, which could demonstrate other factors associated with transmission of the disease? And I'm going to leave it at that for now. There are some additional comments, but I think let's take those three and then we'll come back.
Great questions. So Virginia, yes, so I think it's very, very complex. In our flu study, it was so the original FIRST, which was a 3-year study, and we followed them up for 10 months each year. We struggled with symptoms so much so that the first year we discarded all the symptom data. And that was because in the first year we had a question, like 5 screening questions. And then if you said positive on any one, we then went into more in-depth. So of course the participants worked that out, and then they didn't want to have a long interview. And so then they, they would not report symptoms because they knew you were going to ask them more. And so, so we really became very cautious about not being over ambitious with symptoms. It's really, really difficult. I mean, imagine someone comes to your home twice a week and asks you twice a week, do you have any symptoms, right? So we had a standard question. We asked the same question every time. We trained our field workers every week on it. We also told them to observe if the child has a runny nose, if the child is coughing, you must ask, I see they're coughing, do they have a symptom? That being said, it is certainly we do under ascertain symptoms. And part of it is just, if your child always has a runny nose, is that a symptom? So especially in young kids, although it's less of an issue with COVID, it's very difficult to ascertain symptoms. Secondly, there may be an element of underreporting of symptoms, and whether that's different in sort of these rural and urban communities who are low socioeconomic status, who do have many other difficulties on a physical level in terms of how they live. How they report symptoms might be quite different from people in Europe or North America or Singapore or wherever it is. But again, that's sort of in the area of anthropology, and I don't know. There may also have been an incentive to not report. We tried very hard not to introduce that, but it was difficult because we about halfway through the study, we introduced a thing where if we prioritized, in fact, we always did, we prioritized the symptomatic samples for testing also. So absolutely, people got to know, like, if they prioritize my sample, could be positive, I could be off work, I could have to self-isolate. And so there may have been some of that. We tried really hard to ameliorate it, but we obviously had to notify them and diagnose them. So it's difficult. That being said, for it to go from 16% up to like 80%, I don't think so, right? So I think it is a low symptomatic fraction, but perhaps slightly higher than what we found. In terms of children, yes, it is interesting. We may have been, the fact that children weren't statistically significantly less likely to transmit, we could have been somewhat underpowered for that, to pick up an age effect. That they were less likely to be an index case, I think maybe it means that they're not picking it up at school. I think at schools, the type of contact at schools, most schools do enforce masking to an extent. So I think the fact that they're less likely to be an index case, it means that adults, I suppose maybe are more susceptible to acquisition or bringing it in. So I'm not sure if I understand the biology of it, but I think it is somewhat reassuring that there's not a big risk from the schools in terms of kids bringing it into the home. And then in terms of the social interaction data, so in our original study, we did some very in-depth work, which we've not analyzed, in fact, because COVID came along. We used these proximity sensor devices. We got people to wear devices that sit on their chest, and then they send a radio frequency transmitted message every couple of seconds, and they measure who's, is anybody else in the household around, and then you can build up the actual contact matrices and relate that to the transmission. And we also, in our original study, did in-depth analysis of ventilation. We worked with, colleagues, sort of specialized in that area. The ventilation stuff, we didn't find any association, so we just didn't do it because it was too much work. And then we also didn't do the proximity in the end because it was too much work. We are doing a similar study, though. We have a different type of household transmission study, a case ascertain study, where we start with a symptomatic index case, and then we go to their house and we follow up everyone just for like 3 to 6 weeks. In that study, we are doing the proximity bit. And the reason in the end we put it on that study is because that way you get the contact patterns at the time of the infection. The problem with FIRST is you're monitoring these people for 14 months. And now when do you do the proximity study? It's by the time you have the results and go in, you've missed the transmission time. So beautiful question. We didn't do it, but we may have similar data from another study. And in fact, it's a subject of the PhD of Jackie Kleinans, who's a student working on this.
That's great. Thanks, Cheryl. There are a couple of other comments and questions. Lots of people saying really interesting and great to get this data from our own setting. And please do come back and tell us once you know about Delta. By then there'll be something else and you'll be extending your study again.
No, we're not. It's too intensive and too expensive.
And then someone is asking whether you think there was a difference in immunological profile between urban and rural, I guess kind of exposure to other coronaviruses or something else in terms of immunity.
So that's a big hypothesis, right? And it's interesting. So the first time I presented this internationally was on what's called the Solidarity Call. There are a lot of other African countries on that call, and they all said like this when I presented the asymptomatic friction, and a lot of them work in rural African settings. They were like, "This is exactly what we see. No one's been believing us. They're telling us we're not testing, but honestly, we can say that people are not symptomatic. It's that's what they observed." And then it's an immunology group. So then there were a lot of people who said, "Yes, it's the coronaviruses and the." But there were some so it may be there is this hypothesis out there that there could be if you have a lot of previous immunologic exposure to other coronaviruses, maybe there's some kind of cross-reacting protection. However, the expert immunologists on that call, there are some groups that it's not a lot published. There's some hypothesis generating stuff published, but some of those groups are really doing more in-depth studies. David Goldblatt in the UK, for example, said they have a big study where they've now characterized people in that way and looking, and it doesn't seem to be. Their impression was there's not a lot of evidence to support that cross-immunity hypothesis. We did have some discussions about whether we should try and look at it. And then the thought was, well, is there really a public health implication? And there isn't. So essentially, we didn't pursue it further. So it's a popular hypothesis. We haven't explored it. And I'm not sure. I'm not an immunologist, but I don't know that there's strong evidence for it. Although, if it's real that the symptomatic fraction is so much lower in our type of setting, I suppose it does beg the question: what is the reason potentially?
Thanks. So I don't see any more questions in the chat or any raised hands, but I have a sort of a bigger picture question for you, which I think you probably knew was coming. So given what we now know about this large asymptomatic fraction, which may not be quite as high as in your study, but which does seem to be high, and even in the UK, in their big seroprevalence and also swabbing study, they also found a very high symptomatic fraction. And what I'm going to ask is, what does this mean in terms of control of the disease, and also given and strategies, the best strategies for control, obviously pending vaccination or as we wait for vaccination, and also with the very high, the fact that even in people who perhaps do develop symptoms, that it seems that it's during that proliferation phase, which is early on, that the viral load is really high and that most transmission may be occurring. So what does this mean in terms of control? And I was chatting to the person who led the study in the UK, and one of the things that she said, which I'm interested to hear your thoughts about as someone who was a flu epidemiologist, is that one of almost, she said, our mistakes with COVID was that we thought it was the same as flu. I don't know if that's true, but she said this is not flu. And it's different to flu, and that the strategies that we've used to control flu may not work in this situation. So I'm interested to hear what you think about that.
Well, I think that's an interesting comment, because I must say, I don't necessarily agree. I think what I learned from the 2009 pandemic is that contact tracing and identification of contact tracing will never work for flu. So in fact, when COVID came and everyone was pushing contact tracing, and I was sort of an outlier, and it became so unpopular I stopped saying it, that this was never going to control the disease. And in fact, I was wrong, right? Because it did work in some settings, and I think that's also hard to explain. How do they control it in China and Korea, and even some places? How can you control a disease like this with active case ascertainment and isolation and quarantine? It seems almost impossible that they were able to do it. I mean, now they test millions of people asymptomatically, you know that, but even early on, they were to an extent able to control it in some high income settings through those strategies. And yet our data suggests it really is very, very difficult. Now, perhaps it's because it's different here. Also, obviously, the infrastructure in Africa, in any country like ours, to actually identify cases and do contact tracing, etc., is very different from some other, especially Asian settings. So I mean, I think what it says is that the focus can't, in terms of disease control, cannot be on case identification, quarantine, and isolation. Whether you can go so far as to say, well, we shouldn't do it. I mean, I wouldn't go that far. I think, obviously, on an individual level, once you know that there's a person who's potentially infectious, you have a responsibility to isolate them and to, and to get their contacts to isolate. Because you may well reduce some of the transmission, but of course on a population level, what we can say is that's not going to have a major impact. It can't be our strategy for control. And I think what it tells us is that it's the much bigger, the broader population level interventions that are important. It's the masks, it's the social distancing, it's the limiting of large gatherings, and then it's immunity and vaccination to an extent. Although that being said, of course, we're not going to interrupt the herd immunity. We're not going to reach the herd immunity threshold. So, but of course, the fact that you're not going to totally interrupt transmission doesn't mean you won't push transmission down. We should, and I keep saying this, but we must at some point start to see herd immune effects, right? That even if we do get waves, they are smaller and they become more like a seasonal respiratory virus and less like a pandemic. And that we can expect to happen the more we vaccinate and as our immunity goes up. But I think that the take-home message in terms of control is if we want to control the disease, it has to be this broad population level interventions that we do all the time, not specific, not anything that's targeted at individual cases.
Thanks, Cheryl. I'm going to take two last questions. We are sort of at the hour, but it's just such a great opportunity to get your answers, and they're related. So the one says that when you did actually test people and isolate them, and once you got those results and they're isolated, did you look at all at whether that at this individual level that you're talking about had any impact on transmission? I imagine, just guessing, quite difficult in the households that you are working with to effectively isolate people from their household. And the second one is related, which is, how did you account for the fact that because you were testing people so frequently, this may itself have impacted on transmission, and that it might have been different in a normal population where you weren't finding all these people all the time? So that's
so there's two.
Yeah.
But so I think in terms of we didn't look at it. It's very difficult to look at. There was some delay, right? Even with the best, we had to still transport them from rural Mpumalanga to the NICD, receive more than 1,000 samples a week or per visit, and then test them. So it was still about a 3 or 4 day. Well, I think it was. The routine was about 3 or 4 days, and in the symptomatics we prioritized. So they were more like 24, 48 hours. So most of the transmission might have happened anyway. And we did have, in fact, a difficult ethical dilemma, and we grappled with this with our safety committee, because almost all of these cases would never have been diagnosed. And it did have in some instances, we had a few instances where it really had a negative impact on people. We had one instance of somebody losing their job, although we managed to intervene and they got their job back. But people were, who are very poor, when you tell them now to isolate for an asymptomatic COVID infection that they wouldn't have known about, or their kids have to stay home from school, etc. We were very concerned about now introducing a negative consequence through our study, which they wouldn't have had to incur. But as I say, they guided us, and in the end, we had systems to ameliorate that. But essentially, I think it was a small, given that most transmission occurs very early on, I think it would have had a small impact, and no, we didn't try and look at it. It was also very difficult to measure. So in fact, we elected just to keep the form short. We could have asked, like, every week, are you isolating, are you hand washing, are you whatever, but that just seemed impossible. And so all we did was like a general survey, which we haven't yet analyzed, to say, like, at the end, like, when you were positive, did you isolate? So we may try and match it up, but I'm not very optimistic. We tried it with the flu study, and it's very difficult actually to do that. And that's why the proximity is much better, right? If you can actually measure social contact, it's just, the other challenges. Then the question of, did we account for the fact that because of frequent testing, we could have changed transmission? I mean, I'm not sure what you mean by that. One of the questions, in fact, is whether could we have been spreading it, right, which is a concern. And we did test all our staff weekly. And we isolated all of them, and the staff testing was actually much more tightly controlled. So we would test them on a Thursday so that we'd have the results on the weekend so that they could be isolated on the Monday to try and avoid that. We haven't done it yet. We do still need a sequence just to make sure that we didn't cause any transmission, although we were very, very strict on PPE and we tried to do the swabbing outdoors. Otherwise, whether the testing would have changed transmission, I'm not sure that it would have. The actual swabbing, I mean, unless it changes your nasal microbiome, which I suppose is hypothetically possible. Whether they change their behavior, I don't know. I would say probably what it means is our estimate is a minimum estimate, right? If anything, they were more informed than the general community and they were much more likely to know they had COVID. So maybe it would have been more.
Great, thanks. We are on the hour, so I'm going to end it there. There are a couple of comments in the chat which you can't see, just talking about some countries where case and contact tracing has worked, at least in part, and the kind of strictness of the isolation and quarantine and extensiveness of the testing. So Cheryl, it remains just for me to say an enormous thank you. It's just been such a privilege to both to hear the talk, but also to hear your insights and answers to these questions. I'm going to officially name you the new Hope Simpson. I think you've redefined what a transmission study should look like. So huge thanks, and we hope to have you back in a few months' time to tell us about Delta. Thanks so much, and thanks everybody for joining and for the engaging questions. Thank you.
Thanks for having me, Mary, and really nice questions. Thanks.
Great, thanks. Bye.
Bye.